Okay, so we're going to start out with respiratory, and then we will also go over some cardiac, and then, like I said, we'll do a quick Kahoot at the end of class. 25 questions. It's not that quick, but both cardiac and respiratory are pretty important in pediatrics. So, like I said, there's a bunch of PowerPoint slides. So hopefully you guys were all able to open these. They are a good reference, but I'm going to go through and point out some things that I know might be new information or that I know that you need to know. So we're going to go ahead and jump ahead to slide number 4. So generally speaking, in kids, respiratory conditions, they happen frequently. Kids get colds all the time. They get runny noses. They can have allergies. So we do have some special terms that you might not have heard before. So the common cold is also called coryza. That's this word here. It's Coryza, and it's just a viral infection of the upper respiratory tract. So the common symptoms are going to be nasal discharge, maybe a cough and sore throat, kind of not feeling well. I think all of you guys have had a cold before. Sometimes when you get a cold, it sets you up for other problems, like maybe a bronchitis or a pneumonitis, or sometimes an ear infection. So a lot of times kids will start out with just like a common cold, which is a common cold for an adult, and then it progresses into something more serious. In contrast to the common cold, kids can also have allergic rhinitis, which is just allergies. It can be allergies to pollen or dust or pet dander or whatever. The main thing is there's no fever. So if they're having an allergic reaction, there's no fever, and the nasal discharge tends to be clear. It's not going to specifically have like a yellow-green color or anything like that, but they can still be sneezing and having watery eyes. So in terms of the general difference between the upper respiratory tract infection and then the allergic rhinitis is that there's really no fever with the rhinitis. And I know that you guys need to know that this common cold is also called coryza. That's the medical term for the common cold. So a lot of times kids will have, especially kids under the age of 2, they can develop something called bronchiolitis, which is like an infection of the upper airway. The most common virus that causes bronchiolitis is called RSV. And kids that have bronchiolitis or RSV bronchiolitis, they need a lot of suctioning to help get that mucus out, liquids to help their secretions stay thin. Usually once they're over the age of 2, they're big enough, their airways are big enough that it doesn't cause them problems. But children that are 2 and under are particularly at risk for like a common cold that starts out and then kind of settles in their chest and becomes a bronchiolitis. As you're getting over the age of 2, so kids that aren't that really young, we worry about a couple of different diagnoses. One of the main ones is going to be croup, and there's 2 words for croup. Croup is the common term, and then laryngotracheobronchitis is the medical term. It's almost always called by a virus, but it can be bacterial. And it usually starts with a mild URA and then it progresses. So, and the common symptom is going to be a barking cough, kind of like, it's also called like a seal-like cough, and then stridor. So does anyone know the difference between stridor and wheezing?
Are we supposed to be able to see the slides?
Yes, I
Oh,
thought
okay,
I
sorry.
had
Sure.
sharing it. Are you able to see it?
No.
Oh, all right. There you go. Sorry about that. Let me go back up here. Thank you for saying something. I'm going to go back up to the first slide that we missed, so that, thank you for mentioning it to me. Here's this first slide here. And this is the word that I was talking about. The common cold is called coryza. And this is the slide that goes over the basic distinction between the upper respiratory tract infection versus the allergic rhinitis. I'll give you guys a second. Thank you for telling me that you weren't able to see that screen. And then I was telling you that kids under the age of 2, they're the highest risk for bronchiolitis, which is like usually starts as a cold and it kind of settles in the chest. And then older kids, we're going to talk now about croup, which is this laryngotracheobronchitis. So croup is still, it's not like in your lower airways, it's still an upper airway infection. But it's not just your nose, it's farther down, closer to your vocal cords. And it causes this really barky, it's also called a seal-like cough. And a lot of times, croup can be pretty scary because they have this horrible barking cough, and then they have the stridor. So this is where I was asking you guys, who knows the difference between stridor and wheezing? Does
Stridor
anyone?
is a high-pitched sound. You can hear it in the upper airways. Wheezing is in the lower airways, and it's usually like a whistle, which you can hear with your stethoscope, or you can hear it with your bare ear.
Okay. And stridor also is inhalation and wheezing is exhalation. So you're going to hear stridor when the kids are breathing in, and you definitely don't need a stethoscope. You can just hear it when they're breathing in. So you hear the kind of like they're having a hard time getting air in, and you'll hear it pass through a narrowed airway, and it makes a high pitched noise. So stridor is something that you can hear without a stethoscope, and it's on inhalation. So if they're having a hard time breathing, then they will prefer to be in an upright position because that kind of facilitates air entry into their lungs. So this is one, if they have any humidification, it can help calm and relax their airway. If they're hospitalized, they're frequently put in some sort of a tent that kind of keeps their air humidified and misty. And sometimes with these kids, if they're going to be treated at home, they'll put them on a dose of steroids to kind of decrease that inflammation in their airway. So croup can lead to something called epiglottitis, and you guys 100% need to remember that epiglottitis is a medical emergency. So this is like a really severe, it's like a croup gone bad, and it's swelling of the tissue right above the vocal cords. So these kids have a very, very hard time breathing. They come in, we call it tripod posturing. So they're kind of leaning forward, they're drooling. A lot of times they're not able to speak because their airway is so tight, and they're very uncomfortable. So it's commonly caused by H influenza type B, which is also Hib. There's a Hib vaccine. So, getting kids vaccinated will also decrease the incidence of epiglottitis. It's usually seen in the 3 to 6 age group, and it's pretty rapid. They can go from not feeling well to being really sick really, really quickly. And like I said, you have to remember that it's a medical emergency. So if you have someone come in with tripod posturing, drooling, unable to speak, really having a difficult time breathing, you need to think it could be epiglottitis, and you need to prepare for intubation. So if you're a nurse in the emergency department or something like that, you need to make sure that, like, if you see these symptoms, you have your emergency airway cart there available, and that you're like thinking ahead and thinking about intubation. So there's a couple of other things in terms of respiratory that are kind of specific to kids, and I just want to go over a couple things briefly. Let me look at my notes here. So smoke inhalation injury. So this is going to be like house fire or something like that. So the main thing that you need to remember in terms of like smoke inhalation is that peak inflammation can happen up to 72 hours after the event. So just because someone is doing okay, as soon as you get them out of the smoky area, it doesn't mean that they're out of that window of danger. So they can really have problems that develop within 72 hours of the smoke inhalation. So that's like a key thing to remember. And a lot of things, you can have that peak inflammation within 72 hours. So just kind of remember that with smoke inhalation also. It's not always like an immediate problem that you're going to see. You have to make sure that you're monitoring them for a few days because they can have problems a couple days out. And then kids can have problems with their tonsils. Does anyone in the class have a kid that's had a tonsillectomy, adenoidectomy? Been around a kid that had their tonsils out? Okay, if you haven't, it's really, really painful when they have the surgery. So you have to be prepared that they're going to need good pain control. And the surgery's, it's down in here. So one of the things you worry about is that if they're swallowing a lot when they come out of surgery, that could be an indication that they have a bleeding at the surgical site that you're not able to see. So in terms like a lot of times on exams, et cetera, they have priority questions. So if you have a kid that's had a TNA and they're swallowing a lot post-op, that's a concern that you need to report, because that could be an indication of post-operative bleeding. And they, cool fluids are best for this particular diagnosis. So like a popsicle is the best thing for them to have, because they can kind of suck on it and it's cold and it can it can help soothe their throat. But a common thing to kind of ask on tests, et cetera, is that, a thing that you really need to monitor for is swallowing after surgery, because that be an indication of postoperative bleeding. And then the last thing that we're really going to talk about in the respiratory section before we do a quick review of the cardiac stuff is cystic fibrosis. So has anyone heard of cystic fibrosis? Has anyone known anyone that's had cystic fibrosis? Okay. So cystic fibrosis, if you ever work in pediatrics, you will certainly have patients that have cystic fibrosis. It's one of the more common genetically inherited diseases out there. And it's what they call an inherited recessive trait. So if you have cystic fibrosis, then you receive that trait from both of your parents. So a lot of times parents don't know. If you only receive the gene from one parent, then you're just a carrier, but you don't have the disease. So a lot of times parents will have a kid with CF and neither parent knew that they were a carrier. So it can take people by surprise. It is on the newborn screen in all 50 states. So they are catching more cystic fibrosis earlier and earlier in life, but it does happen. Parents don't know that they're carriers, and if both mom and dad are a carrier, they can have a kid that has cystic fibrosis. So we primarily think about it as being a lung problem, but it really produces increased thick mucus throughout the body. So in the lungs, they're set up for infection because they have this thick mucus and the bacteria gets trapped in there, and then they get an infection. But it also affects their pancreas. So they have a hard time digesting fats in particular, because the glands in their pancreas that secrete digestive enzymes, they're not able to secrete it because they get clogged with mucus. So they lose a lot of salt in their sweat. So they literally taste salty. So they need electrolyte replacements, and then they need pancreatic enzyme replacements to kind of help them be able to digest their food. So, remembering that it's a multi-system disease, so it's respiratory, digestive. They lose a lot of salt, in particular through their skin, and then it can cause infertility. So particularly in boys, it causes them not to produce normal sperm. So generally speaking, like if for patients, I think like the average life expectancy is probably around age 30, but they will do lung transplants in patients. So if they do the lung transplant, that tends to, even though the sperm are obviously not near the lungs, but usually when they get the lung transplant done, they are no longer infertile. But they do need to be aware. If you're a boy with cystic fibrosis, you need to have genetic counseling about your possibility or lack of possibility of having children. And women also might need to talk about it too, because the life expectancy isn't very long. So they should be thinking ahead and making appropriate decisions. So those are the things that I really think are kind of different about the respiratory in kids versus adults that I really wanted to point out. Does anyone have any questions about those key points? Okay, I'm going to pull up the cardiac, and then we'll do your Kahoot really quick. Okay, so the main difference between kids and adults when we're talking about the heart is that kids that have heart disease, they usually have what we call congenital heart disease. It's usually not acquired. So adults, they have high blood pressure, they have high cholesterol, they smoke, maybe they have diabetes, and all of these problems can lead to cardiac disease over time. But children, if they have heart disease, they're usually born with it. So congenital just means something that you're born with. And we classify congenital heart defects as cyanotic versus acyanotic. So does anyone want to wager a guess? What do you think cyanotic means?
Lack of oxygen.
Lack of oxygen. So right, we categorize heart defects in terms of, do they have an oxygen level that's lower than we expect it to be, like not above 90, or do they have an oxygen level that's normal? So this is the picture of the heart here, and this, everything that's blue here is the right side of the heart, and everything that's red is the left side of the heart. So, you know, cyanosis, think about blue. So think about something going on the right side of the heart, not getting enough blood flow to the lungs is what's going to lead to that cyanotic defect. Whereas if it's something on the other side of the heart, it's probably not going to lead to blueness because, you know, the right side is what gets oxygen out to the lungs. So just to do like a quick review, this is your superior vena cava and this is your inferior vena cava. So these two big veins, they drain blood from the body, they go to your right atrium, and that blood flow then goes to your right ventricle, and then it goes out to your lungs. So this here is the pulmonary artery, and it branches off to both sides to go to each lung. And then the pulmonary veins return blood to the left atrium, and then goes down to the left ventricle, and then it goes out the aorta here to your body. So the right side of the heart receives the deoxygenated blood from your body after it's gone to all your tissue. It sends it to the lungs where it picks up oxygen, and then it goes to the left side, and the left side pumps that blood that has oxygen to your body. So in addition to talking about like, is your oxygen level low or normal, cyanotic or acyanotic, we talk about, does it cause increased pulmonary blood flow? Is there an obstruction of blood flow? Is there decreased pulmonary blood flow? So always think about the heart and the lungs go together. So, you know, even though we're talking about a heart defect, we often talk about what effect that has on the blood flow to the lungs. And then there's another term that we talk about in pediatric cardiology, and that's shunt. And shunt just refers to blood that moves through an abnormal opening in the heart. So this next slide here is going to show you all the different ways when we talk about shunting. So this is the review again of the normal blood flow, where it comes, you know, returns to the right atrium, your deoxygenated blood goes to your right ventricle, goes out to your lungs, comes back from your lungs to the left atrium, goes to your left ventricle, and then out to your body. And this one here, this second box here, it says atrial septal defect. So the top two chambers of your heart are the atrium, and the bottom two chambers of your heart are the ventricles. And you can see here there's a hole. So the atrial septal defect is there's a hole in that top chamber of the heart. And this blood is shunting. You see that it's coming from the lungs to the left atrium, and then it goes over to the right atrium. So this is called a shunt because this is an abnormal hole. This is your ASD, your atrial septal defect, and the blood is shunting through that hole. And this next one, it says ventricular septal defect. So in here, there's a hole between the two ventricles, and the same thing, there's a shunt. So in terms of both the ASD and the VSD, something that's kind of key to remember is the left side of the heart has a higher pressure than the right side of the heart. So blood flows down a pressure gradient. So since it's a higher pressure over here, it goes from the left side to the right side. So what do you guys think? If you have a hole and it pushes blood from the left side to the right side, and the right side then takes blood to your lungs, does that cause increased pulmonary blood flow or decreased pulmonary blood flow?
Increased.
Increase. Very good, Matthew. So you have it here on your left side. It shunts to your right side. So there's more blood on your right side. So then it's going to go to your lungs and cause increased pulmonary blood flow. So atrial septal defects, ventricular septal defects, and this one here, which is the patent ductus arteriosus or the PDA, these all cause increased pulmonary blood flow. And if you have increased pulmonary blood flow, is that cyanotic or acyanotic?
Acyanotic.
It's acyanotic. Very, very good. So you have too much blood going to your lungs, so you're not gonna have a problem getting oxygen into your blood because you have more blood going to your lungs than you need. So it's acyanotic. So this patent ductus arteriosus, this one I think makes the most sense if you look at this picture here. So this is your pulmonary artery, and this is your aorta. So the patent ductus arteriosus is a communication between these two big vessels. In this picture here, they show it as like a bar across the bottom. It doesn't really matter, it's up at the top. As long as you understand that this vessel here, your pulmonary artery, is taking blood to your lungs, and this vessel here, your aorta, is taking blood to your body. So when you have a connection between these two, you drain blood from your aorta into your pulmonary artery and it goes to your lungs, because this is still a higher pressure because it's the left side of your heart. So the patent ductus arteriosus also causes increased pulmonary blood flow. So it's a connection here. You know, there's an opening between the pulmonary artery and the aorta, which in this diagram here, they show it down here. There's a connection here to these, in those two, they call the great vessels. So that causes more blood flow to go into your lungs also. The coarctation of the aorta, which is the slide in the second row on the bottom. So the aorta here, again, is this big vessel here. So coarctation is narrowing. So this is an obstruction lesion. You see it here, they made it narrowed at the bottom. So that means the body has a harder time getting blood out to the body. And then the tetralogy of Fallot, we're going to go over in more detail, but it's one of the more common ones. And it has 4 things, but we'll have a whole nother slide on it. I just want to say that you should study tetralogy of Fallot because you're going to see it on a lot of exams going forward. It's a fairly complicated defect, but it's heavily tested in the world of nursing. And this goes over what we just talked about on those slides. And this is the difference, you know, this is the cyanotic, acyanotic versus the cyanotic. So we talked about these here: ventricular septal defect, atrial septal defect, patent ductus arteriosus. These are the 3 that are associated with increased pulmonary blood flow, and they're acyanotic. And coarctation, that's that narrowing of the aorta. So that's not even related to the lungs at all. So this is also an acyanotic. And these other ones over here, the tetralogy of Fallot, transposition of the great artist, trunctus arteriosus, these are cyanotic, so they cause the baby to be a little bit more blue. The one that we're going to really talk about is tetralogy of Fallot, because it's the most common one in this category. And it's the one that you're going to be tested on the most. So the coarctation of the aorta is the narrowing of the aorta. So there's the problem with getting blood flow out to your lungs. I'm sorry, not out to your lungs, out to your body. So this one, depending on the severity of the narrowing, they might not have symptoms early in life. They might be later childhood, even adolescence, before they have symptoms. So what do you think? This is your picture here of the narrowing. What do you think you might see if you're examining somebody that has a problem with getting blood through the aorta out to their body? Just logically speaking, what might you see in the patient? Do you think their blood pressure is normal? Do you think it might be different? If you have a hard time getting blood out from your heart to your body, how could that affect your blood pressure?
Probably gonna be low.
All right, very good. So specifically, it's lower in your legs than in your arms. So there's a blood pressure discrepancy. This picture is a little bit off. You see these 3 branches here. So this branch here goes to your upper body, and usually the narrowing's after that first branch. So usually you get normal blood flow to your head and your arms, but then you have a harder time getting blood to your lower part of your body. So you almost always, like, a common thing to test for coarctation of the aorta, you have a blood pressure discrepancy between your arms and your legs. So it's lower in your legs. And for the coarctation of the aorta, they sometimes they can take them into the cardiac cath lab and balloon that narrowing open, or sometimes they have to do a surgery. So now we're going to move on to the decreased pulmonary blood flow, and bar none, the most common defect that causes decreased pulmonary blood flow is going to be your tetralogy of Fallot. And the tetralogy of Fallot is four things that have to be true. So tetra, think of 4. So there's pulmonary valve stenosis. So there's problem getting blood out the heart to the lungs. There's right ventricular hypertrophy. So the ventricle on the right side has to push harder to get across that stenosis. So that makes that muscle thicker. They have what they call an overriding aorta. So the aorta is pushed to the right side. And then they also have a ventricular septal defect. So there's 4 things that go into the diagnosis of tetralogy of Fallot. So this is another one that they're not always diagnosed right away. There's a wide variety of severity. So as they get older, they could have what they call clubbing of the fingers, where you see their nail beds look kind of fat and wide, and you can see blueness in their nail beds also. And they tend to do this squatting position. So this little girl is kind of what when we talk about a squatting position, that's what we're talking about. So the squatting position, it increases the blood flow to the right side of the heart. So then you have more blood flow to go to your lungs. So that's a common thing also to ask on NCLEX, HESI, etc., is why do kids with tetralogy of Fallot squat? And they squat because that increases their venous return. So if they have more blood on the right side of their heart, then they have more blood to go to their lungs. So, certain things that you would see with this patients before they have surgery to fix it, they can have feeding problems. They maybe aren't gaining weight well and get respiratory infections. And then they have polycythemia. Does anyone know what polycythemia means?
Is that extra red blood cells?
It is. So the red blood cells are the cells in your body that transport oxygen. So if you're having a hard time getting oxygen to your body because you have an obstructive lesion on the right side, and blood's not going out to your lungs to pick up oxygen, your body instinctively produces more red blood cells to try to offset your decreased oxygenation. So since you have more red blood cells, you have a higher likelihood of getting oxygen to your tissue that you need. So this is something that you'll see, like a hematocrit, like 45, 48, higher than it should be, because they're compensating for their lack of oxygen. So there's paroxysmal hypercyanotic episodes is like the medical term, but like the lay term is TET spell, or tetralogy of Fallot spell. And they almost look like they're going to pass out, or they pass out. So they're playing or something, they're getting agitated, and they don't have enough oxygen because they're not getting enough blood to their lungs. So they kind of like drop to the ground and go limp. So if this happens, what you do is what's called a knee to chest position. So you push their knees into the chest, kind of like they do when they squat instinctively, and that pushes blood back to their heart, so then they can get more blood flow out to their lungs. So this is the main thing that you need to know. Place child in the knee to chest position when the TET spell occurs. So that's your nursing intervention. You put them flat on their back and you push their knees into the chest. And what that does is that increases their venous return, and then that'll increase the amount of blood they can go out to their lungs. So there are certain things that you need to think about in terms of heart disease in children. they're almost always, they almost always need surgery early in life. Most major hospitals have like a specific cardiac ICU for kids that have cardiac defects. And the nurses, are trained, and they know more than the average nurse graduating from nursing school about the defects. It can be really hard on parents. They need a lot of emotional support. And things that you should always be thinking about, if you have a kid that's not gaining weight well, that's one of the main things that you need to be aware about in kids that have heart disease. It's not always diagnosed right away. Sometimes kids are not diagnosed right when they're infants. So if you have a kid that's sweating when they eat, or they get tired when they eat, or they're not gaining weight well, or they're having frequent respiratory symptoms, those can all be signs that they have undiagnosed congenital heart disease. So I started out, when we did the quick cardiac review, saying that usually in kids it's congenital, but they can have acquired heart disease also. It's just not as common as it is in adults. So acquired heart disease would be something they're born, and then, because of hypertension or high cholesterol, et cetera, they end up developing acquired heart disease. So you're going to see acquired heart disease usually be more of like a teenager. This is not something that you expect to see in childhood, but they can develop like a myocarditis or something like that, which is like an infection of the lining of the heart, and that can happen in childhood, and that is another kind of cause of acquired heart disease in children. So this is the same thing. I think all of you guys have taken med-surg. You always think about left-sided versus right-sided heart failure. So it's the same basic symptoms in pediatrics. So left-sided heart failure, weakness, dyspnea, so the left side gets the blood out to the body, and if it's not able to do that, it backs up into the lungs, so then they can hear like crackles, and they can have a hard time breathing. Whereas on the right side drains, the veins drain to the right side of the heart, so then they end up with like edema. They're not draining their fluids, so they can have abdominal ascites, nausea. This is the same in pediatrics or adults, but you should be able to pinpoint left-sided versus right-sided heart failure. And these two slides, so 29 and 30, give you like a description of the two different types of heart failure, left-sided versus right side. So like I said, in kids, most of the time it's congenital and not acquired. And there's certain things that you don't always necessarily associate with cardiac that you should think about could be undiagnosed. It could be an early sign of congested heart failure. So tachycardia at rest, when they don't have a fever, when they're not upset, they're calm, and they're have a high heart rate. If they're not feeding well, that's the big one. You worry a lot about kids that aren't able to eat. If they're sweating unusually, or if they have dyspnea or weight gain. So these are kids that are maybe not going into heart failure, and they're not able to process their fluids, pump their fluids normally throughout their body. So the ones that you're going to see really first are going to be the tachycardia at rest and the fatigue during feeding. So those are the things that you really worry about. That could be like an early sign of congestive heart failure in a baby. So that is the quick, skinny and dirty on cardiac. The things that I know that you need to know tetralogy of Fallot. You need to know which defects cause increased pulmonary blood flow, and you need to know what a shunt is. So I'm going to give you guys like a few minutes to stand up, go to the bathroom, come back in 5 minutes, and we'll do a Kahoot, and then you guys will be free to go. Okay?
She's not actress. She's not Adrian's. Let's go. In position. Or on the website,
I see them. Another 2 hours running. Heck, there's almost nothing in the world.
you know, Adrian had it in this place and he let it run online.
Okay, so I think most of you all are back. Go ahead and flip your camera on so I can see your pretty smiling face. There's something I forgot to mention that I know is going to be on your Kahoot, so I'm going to give you a fair chance of getting it right. So strep throat can cause something called rheumatic fever, which primarily is inflammation of your heart valves. So if you develop rheumatic fever, you have to take antibiotics for 5 years. So the primary antibiotic is penicillin. So this is something that you'll see again. It's going to be on the Kahoot to reinforce it, but I know we didn't go over it in class, so I just wanted to give you the heads up so you guys would have a chance of getting that one right. So the game pinch is going to load in just a second. Okay, so I'm going to go ahead and start, and I'll post the Kahoot for you to practice at home also in the announcement. So a positive throat culture for group A hemolytic strep would be treated with what? Tylenol and fluids, immunization, penicillin for 10 days, or penicillin until the sore throat is gone. Yeah, so penicillin until the sore throat is gone. So that's going to be your strep throat. And then if you develop rheumatic fever, like if you didn't get your initial antibiotics and then you go on to develop rheumatic fever, you have to take the penicillin for 5 years. So acute coryza is another name for what? Dyspnea, tonsillitis, the common cold, or croup. Yeah, so that's the common cold. That's the other name for the common cold. So acute croup is also called what? Bronchitis, asthma, laryngeotracheobronchitis, or epiglottitis. So yeah, this is the laryngeotracheobronchitis, is the other name for croup. And then epiglottitis is the actual inflammation of the vocal cords right there. And that's going to be the one that's always the medical emergency that you need to remember. So what will the nurse teach the child with cystic fibrosis to facilitate digestion of nutrients? Salt supplements, fat-soluble vitamins, pancreatic enzymes, or water-soluble vitamins? So they need their pancreatic enzymes. This is, they have, thick mucus that clogs their pancreatic ducts, so they can't secrete the enzymes that they need to digest their food. They also frequently take fat soluble vitamins, but that doesn't facilitate digestion of nutrients. That what they need to digest their nutrients are their enzymes. So which congenital cardiac defects cause increased pulmonary blood flow? ASD, VSD, PDA, tetralogy of Fallot, aortic stenosis, pulmonary stenosis, coarctation of the aorta, pulmonary stenosis, VSD, or VSD, aortic stenosis, tricuspid atresia. All right, so it's this one here, the red one, ASD, VSD, PDA. These all have a left to right shunt and they cause increased pulmonary blood flow. This is something that you guys definitely need to remember and be able to pick out. These 3 defects are associated with increased pulmonary blood flow. A child swallows frequently after a tonsillectomy and adenoidectomy. What might this indicate? Potential vomiting, pain at the incision area, bleeding from the surgical site, or sore throat from postnasal drip. So yeah, you're worried about bleeding at their surgical site if they're swallowing all the time, because you won't always see the blood because it's a little bit farther down in their throat. So you need to report that to the provider or the surgeon if you're taking care of a patient that's had a TNA. So the parents of a 3-month-old with cystic fibrosis want to know how their child got the disease because neither parent has CF. Only one parent carries the gene. The inheritance pattern is multifactorial. Both parents are carriers, or the result is probably a genetic mutation. Yeah, so it's a recessive disorder, so that the gene has to come from both parents for the kid to have the disease. So which fluids are appropriate for a child with asthma experiencing dyspnea and fluid loss? Carbonated beverages, iced fruit juice, room temperature water, or cold milk? All right, so good job. The carbonated beverages could be irritating and make them cough more, and same with the cold that can cause like a bronchospasm. So the room temperature water is best if you're having a hard time breathing or if you're experiencing any sorts of airway constriction. So how long after smoke inhalation are patients at greatest risk for pulmonary edema? 72 hours, 4 hours, 18 hours, or 2 hours? All right, good job. So that one's the 72 hours. So they're really at risk for up to 3 days after the injury. So which intervention will the nurse suggest to the parents of a child experiencing a barky cough? Bring the child directly to the emergency department, take the child outside to cool air, use a humidifier, or take the child into a steamy bathroom, or have the child drink plenty of fluids. So this is the barky cough. This is the croup, and then when the main thing they need is some humidification. So a humidifier at home or a steamy bathroom is the best thing. What findings are expected when measuring the blood pressure on all 4 extremities in a child with coarctation of the aorta? Blood pressure lower in the arms and in the legs, blood pressure higher on the left side, blood pressure higher on the right side, or blood pressure lower in the legs than in the arms? Yeah, very good. So this is the one where you're going to expect it to be lower in the legs than in the arms. That's a classic finding for coarctation of the aorta. So blood flow between vessels of the heart is called a shunt, turbulence, atresia, or stenosis. So that's your shunt. It can also be between 2 different, like the atrium or the ventricle, but very good. Think about left to right shunt causing increased pulmonary blood flow, your ASD, VSD, and your PDA. So what is an atrial septal defect? Abnormal opening between the heart's upper chambers, connection between the lungs and the aorta, abnormal opening between the heart's lower chambers, or a stenosis of the tricuspid valve. All right, so abnormal opening between the upper chambers. So the upper chamber are called the atrium. So an atrial septal defect is that upper chamber of the heart where there's a hole between the right and the left. Hey, Joaquin Bata. What is the lowest acceptable oxygen saturation that must be maintained on a child? Above 96, above 88, above 90, above 86? So I think most of you guys got that. So generally speaking, you're thinking like normal oxygenation, you always want it above 90. So why do children with tetralogy of Fallot favor a squatting position? It decreases atrial blood flow away from the heart. It's a common resting position. It increases the venous return back to the heart, or it increases the workload of the heart. All right, good job. So this increases the venous return back to the heart, so then they have more blood that can go to their lungs. So this is something you guys want to make sure that you make a note of this. This is why they squat like that. It increases their venous return. Which comment by the parent of a 1-month-old would raise concern about a possible congenital heart defect? He sleeps all the time, he tires out during feedings, he's fussy for several hours a day, or he's always hungry. Yeah, so one of the main things we worry about with babies is they have a hard time eating. They're sweating and they're having a hard time eating. So tires out during feedings is not normal, and that would definitely make you think that maybe he has a undiagnosed heart defect. What does the nurse explain that a ventricular septal defect will allow? No shunting because of high blood or high pressure in the left ventricle. Blood shunts from left to right, causing increased pulmonary flow and no cyanosis. Increased pressure in the left atrium impedes circulation of oxygenated blood, or blood shunts from right to left, causing decreased pulmonary blood flow and cyanosis. All right, so yeah, so the correct answer is that shunt from left to right, causing increased pulmonary blood flow. So there's 3: ASD, VSD, PDA, and this statement is true for all 3 of those, that it causes, or there's a left to right shunt with increased pulmonary blood flow and no cyanosis. So this ventricular septal defect is also called a VSD. So the VSD, the ASD, and the PDA, or the patent ductus arteriosus, this is common for those 3: left to right shunt, increased pulmonary blood flow, and no cyanosis. What is a non-invasive procedure? So we didn't talk about this one, so I'm going to skip it because you guys, it's an echo. So rheumatic fever causes which inflammation? Carditis, inflammatory bowel, tonsillitis, or macular rash? All right, so it does cause carditis. So the main thing you worry about with rheumatic fever is mitral valve heart disease. So to kind of remember that with rheumatic fever, the primary symptom that you're worried about is cardiac valve disease. Through what does, so we're going to skip this one also because we didn't talk about it. So a child recovering from rheumatic fever needs to receive monthly injections for 5 years of what medication? Prednisone, penicillin, Benadryl, or Zosyn? All right, good job. Penicillin, very good, you guys. So this is usually starts as a strep throat that's not properly treated. If they develop rheumatic fever, then they need the antibiotics, penicillin specifically, for 5 years. What medical emergency is caused by an infection that swells around the vocal cords? Croup, tracheitis, esophagitis, or epiglottitis? So yeah, this is the epiglottitis. This is the one that you always need to remember is a medical emergency, and you need to be prepared for intubation if your patient has epiglottitis. So the nurse should prepare for emergency intubation when caring for a child with what diagnosis? Asthma, bronchiolitis, epiglottitis, or Kawasaki disease? Yep. So epiglottitis, good job, you guys. We're almost done. I know I'm letting you out a little bit late today. I apologize. So how do you treat primary hypertension in a child? Encourage moderate activity, give Lasix at bedtime, encourage a high salt diet, or refer to an endocrinologist. So yeah, you would start off with encouraging moderate activity. They might need a referral to an endocrinologist, but the first thing you're going to do is diet and exercise modification. So encourage moderate activity. So what is the difference between a HDL and LDL? We're talking about cholesterol. HDL reduces the risk of plaque buildup. LDL increases the risk. They're the same thing. HDL is a protein, LDL is a lipid. HDL is higher in cholesterol than LDL. So you always think about the good cholesterol and the bad cholesterol. So the HDL increases your risk of plaque buildup. It's the bad cholesterol, and LDL, I'm sorry, I said that backwards. HDL reduces the risk, so that's the good one, and the LDL increases it. So you want more of your high density lipoproteins and less of your low density. So good job, everyone. All right, very nice. Who's our runners up here? Ollie and Michaela. Nice job, everyone. So I think you guys all know that you have a quiz next week. So the only thing I'm going to say is that I'm going to post this Kahoot in the announcement, and I would go over the Kahoot to study for the quiz. I think if you know all the answers on the Kahoot, then you're going to do fine in your quiz next week, and we'll take it at the beginning of class. We're going to meet again on Saturday to go over your tests. So I won't post your exam scores until Saturday afternoon. Does anyone have any questions?
Did someone already ask about the question on the exam that was twice?
There was a question on the exam that was twice. It was on there twice.
Yes.
Oh, no, no one has asked me. What was the question? Do you remember?
Yes. It was inflammation around the brain and spinal cord.
And that was on there twice?
Yes.
Okay, I'll look into it. No, no one asked me anything. Thank you for letting me know.
Yeah, I noticed that too. I thought I was misreading it, but I noticed that also, unless I did misread it.
Okay, I'll go in and take a look. Thank you for letting me know. Are there any other questions?
For the week 6 HESI-PN case studies, I don't see it in the Evolve. It's not showing up.
Is that just for you, or is it for everyone?
I'm not sure.
Is anyone else having problems? Let me log in.
None of them are showing up in mine either. So
Yeah, they're not showing up.
All right.
Showing up, and I already did them. The
Okay.
one.
Yeah, because they usually just show up the week that they're due. So it's not that you would see all of them, you would just see the one. But I will take a look at it and make sure that it's set up. So give me till the end of the day. So if you can check back tomorrow morning and look and see, and I'll look at it today to see what's going on.
Okay, thank you.
You're welcome. Any other questions? Okay, you guys have a good day. I'll see you next week. Bye-bye.
You too.